Let's jump right into this explainer. If you've ever sat in a clinic, heard the word biopsy, and instantly felt that wave of anxiety hit you, you are absolutely in the right place. Today, we're breaking down exactly what a skin biopsy is, and more importantly, what you should actually expect. So let's get right to it. Just a quick note before we dive in, the evidence we're covering is current as of July 11th, 2026. It's been reviewed by Dr. Thomas Hocker of SkinTrust.com, who is a triple board-certified dermatologist, Mohs surgeon, dermatopathologist, author, and educator. And remember, this is general, evidence-based education, not individual medical advice. Okay, so let's start with the direct answer. What actually is a skin biopsy? Basically, it's a sampling strategy. It's done to answer a very specific diagnostic question, not necessarily to just remove a whole spot right then and there. Now, dermatologists have an incredibly trained eye, right? They can learn a ton just by looking at a lesion. But sometimes surface appearance just isn't enough. Some dangerous skin cancers can perfectly mimic totally harmless moles. Or a doctor might know a spot is abnormal, but they really need to see exactly how deep those cells go. That's where the microscope comes in. It gives them that undeniable microscopic proof they need to plan your care safely. But, sitting there in the clinic, this raises a really natural question. If a spot looks suspicious, why wouldn't the doctor just remove the entire thing right away? Why just take a sample? It kind of feels like a half measure, doesn't it? Why not just get rid of the whole shebang while you're already in the chair? Well, think about it like this. Taking a biopsy is exactly like taking a core sample of the ground before you build a foundation. You wouldn't just bring in bulldozers and excavate an entire property before you even knew what kind of foundation you needed, right? The same logic applies to your skin. A dermatologist's major priority is preserving your healthy tissue. So for a large spot on the face, you might only need a tiny representative sample to figure things out. This literally saves you from unnecessary risks, longer healing times, or a big scar if the spot ends up being completely harmless. You want hard evidence first. Section 1. Choosing the right technique. Let's see how they decide what to do. What's really fascinating here is how a dermatologist actually works backward from the question they're trying to answer to pick the right tool for that core sample. They definitely don't just guess. There really is no single best biopsy. It's all about getting the right depth and shape without taking more tissue than necessary. For example, if they just need to look at the surface, a superficial shave takes only the top layers and usually heals up super fast. But if they need to look deeper, a deep saucerization takes a broader, bowl-shaped sample. Then there's a punch biopsy, which takes a round, full-thickness core. Honestly, it's kind of like a tiny cookie cutter. You also have incisional biopsies, which just take a portion of a really large lesion, and excisional biopsies, which remove the whole visible lesion with a narrow margin. Basically, the medical names matter way less to you than the fact that the doctor is tailoring the depth and shape to minimize your downtime while maximizing the accuracy of the diagnosis. Now, this is absolutely crucial. If melanoma is suspected, the depth of the sample is everything. Measuring that depth, which is called the Breslow thickness, is the single most important factor for staging and figuring out treatment. Because of that, a simple superficial shave is almost always avoided in those cases. Think about it. If a shave biopsy is too shallow, the blade could slice right through the middle of the tumor, leaving the deepest part behind. That makes it literally impossible for the pathologist to get an accurate measurement. Since getting that depth right carries so much weight, deeper techniques like an excisional, a punch, or a deep saucerization are definitely the way to go when melanoma is a possibility. Section 2. What to expect during the appointment. Let's walk through the actual visit. So, let's walk through what actually happens when you sit down for the procedure. It's a highly structured sequence that usually takes just a few minutes. First, they confirm the exact spot. They'll probably snap a quick photo or draw a little map so they can find that exact millimeter again later. Second, they clean the skin and inject a numbing medicine. Third, they carefully collect the tissue. Fourth, they control any bleeding and close the site up. And finally, that little sample gets routed straight to the pathology lab. It's super fast, highly practiced, and designed to get you in and out safely. Now, if you're feeling anxious about the pain, which is totally normal by the way, let this number reassure you. In one dermatologic surgery study, a full 93.3% of patients reported absolutely no pain during the procedure once the numbing medicine kicked in. Seriously, that is a massive majority experiencing a totally pain-free procedure. So, in real terms, what this means is you should expect a quick sting or a little burn from the initial injection itself. But once that area is numb, you're mostly just going to feel some pressure, maybe a little pushing or movement. You really shouldn't feel anything sharp. And hey, if you do feel something sharp, speak up right away. Tell your clinician so they can just pause and give you a little more numbing medicine. Seriously, there are no medals for toughing it out.
After the sample is taken, they'll stop the bleeding, and depending on the technique, you might get a stitch or two, or they might just bandage it up to heal on its own.
Section 3. Next steps and your results. Okay, so you leave the office and your sample heads off to the lab. Let's talk about what those results actually mean. A really important concept to understand here is that skin lesions can be heterogeneous. That's just a fancy medical term meaning one part of a spot can look completely different from another part under the microscope. Think of it like a slice of marble cake. If you only scoop out the vanilla part, you'd have no idea there's chocolate right next to it. Because of this, a partial biopsy might perfectly diagnose the spot, but it could still miss a deeper, more aggressive growth pattern just a tiny bit away. So if your treatment plan changes later when more tissue is removed, it doesn't mean that first biopsy was a mistake. It just means it did its job as the essential first step in gathering evidence. And this quote perfectly grounds our expectations. The best biopsy is not the biggest biopsy. It is the smallest biopsy that reliably answers the question without sacrificing information the next decision will need. I love that. The whole goal is diagnostic precision, not just hacking everything away immediately. It's all about getting the exact amount of information required for your next step. No more, no less. So let's say a week goes by, you get your lab report, and it says the tumor reached the edge of the biopsy sample, what doctors call a positive edge or a transected margin. Should you immediately panic and think the procedure failed? Generally, no. Don't panic. Remember, the biopsy was just for diagnosis, not definitive treatment. Definitive treatment is the final step to actually cure or remove the disease. It is incredibly common for a diagnostic sample to leave a little tumor behind. But let's look at the flip side. A supposedly clear margin on a tiny biopsy doesn't guarantee the cancer is 100% gone either. In fact, one literature review showed that for skin cancers with supposedly clear biopsy margins, residual tumor was still found later during the actual treatment in 24.9% of cases. That is literally a quarter of the time. And that is exactly why your actual treatment plan follows the diagnosis, rather than just trusting the edge of a tiny diagnostic sample. To make sure you're totally prepared for what comes next, you need to walk out of that clinic with 3 specific plans in mind. First, know exactly how to care for your site. Please skip the generic internet wound care advice and follow your doctor's exact instructions for dressings and showering. Second, know the timeline. When and how will they communicate your results? A phone call, a patient portal? Find out. And third, understand what the next decision point looks like, whether the results come back benign or cancerous. You can really empower yourself by just directly asking your clinician a few simple questions. It transforms a really anxious moment into a clear, evidence-based conversation. Try asking, what diagnosis are we trying to confirm today? Which technique are you planning to use, and why does it fit this spot? Like we talked about earlier, knowing if it's a shallow shave or deep punch tells you a lot about what they suspect. By just asking these things, you become an active participant in your own care. At the end of the day, your biopsy is just step 1 in gathering the hard evidence you need. So take a breath, ask your dermatologist questions, and take comfort in knowing you have a solid plan moving forward. Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. Thanks so much for joining us for this explainer, and stay empowered on your health journey.